Welcome everybody to our webinar on the framework for medical respite care. We're going to give folks just another minute or two to join us before we get started. But we're so grateful that you are here today, and we'll get started in just a minute. All right. Well, we do have a lot of good information, and it looks like we have a lot of folks here. So we're going to go ahead and get started with our webinar. Again, thank you everybody for joining us today for our webinar, The Framework for Medical Respite Care, Understanding and Application for Programs. I'm going to touch on just a few sort of level setting activities before we get started for today's webinar. First of all, you'll notice that we are in a webinar format today. And so for any questions, we're going to have a discussion time at the end. But please use the Q&A feature, which is at the bottom toolbar of your screen. It should be there. Please click on that to submit questions. We'll be able to use that to answer questions live at the end of the presentation. But we also may be able to respond to those throughout the webinar as we're speaking on different topics. So please use that for a Q&A. You're also welcome to use the chat feature to introduce yourself, but we ask that any questions go through that Q&A feature, and we'll be getting to those. I'm Caitlin Sinovic. I'm our Assistant Director for Medical Respite. I'm joined today by my colleagues, Stephen Wilder and Julia Dobbins, who will also be presenting and participating in our discussion a little bit later. Before we get into our content for today, it is our practice here at the National Healthcare for the Homeless Council to begin our activities with a land and labor acknowledgement. Noting that we are all in a virtual space, many of us are coming from and are located in different communities across the country. But although we're together in a virtual space, we are all interconnected by the land beneath us. Most of our communities reside on unceded ancestral lands or were acquired by unhonored treaties. We acknowledge the people of these lands, past and present, and honor with gratitude the land itself and its people. We also want to take a moment to honor the brilliance and humanity of all immigrant labor, including voluntary, involuntary, trafficked, forced, and undocumented peoples, whose labor remains hidden in the shadows, but still contributes to the well-being of our collective community. By recognizing the land that was taken from first Americans and the forced labor that was provided by enslaved Africans and Black and Brown people, we strive to take steps towards creating a more equitable and just world for all of us. And Stephen has shared in the chat some links. I would encourage you all to take a moment and look up your own history of the land that you're residing on and to learn more about the space where you are located. So likely you all came to us because you're familiar with the work of the National Healthcare for the Homeless Council, but in case you're not familiar, we're a training and technical assistance organization whose mission is grounded in human rights and social justice, with a goal to build an equitable, high-quality healthcare system through training, research, and advocacy in the movement to end homelessness. Part of the work of the National Healthcare for the Homeless Council is the National Institute for Medical Respite Care, which I'm sure many of you are most familiar with here in the medical respite space. NIMERC is a special program of the council, and our work really focuses on expanding medical respite or recuperative care programs across the U.S. By delivering consulting knowledge and providing information to you all on best practices in medical respite care. Which is a great foundation to start off our conversation and really the topic of our presentation today. So we are going to focus today's webinar on really talking about the framework for medical respite care. We have a lot of resources around this and some foundational documents, but we haven't had the opportunity to really dive into what these are in a collective virtual space. So that is the goal of our conversation today. So to provide an overarching information around the framework of medical respite care, the framework really seeks to define the philosophy of medical respite care, and articulates how other foundational resources, our guiding principles, our standards for medical respite care, and our models of medical respite care are used in conjunction to provide quality care and an opportunity for recovery for people experiencing homelessness. So we have these three documents together that we're going to go through each of these individually, but it's important to understand that these should all be utilized together in order to provide the best services. Before we dive into those foundational resources, we do want to take a moment just to provide our central definition of medical respite care. Medical respite care is defined as acute and post-acute care for people experiencing homelessness who are too ill or frail to recover from a physical illness or injury on the streets or in shelter, but who are not ill enough to be in a hospital. We know that programs vary in size and structure, but despite the differences among them, they all provide a short-term safe place to stay, allowing people experiencing homelessness an opportunity to rest, recover, and heal in a safe environment while accessing medical care and supportive services. It's also important to note that in the field, you'll hear the terms medical respite care and recuperative care. These terms can be used interchangeably as they describe the same service. It's important for us to have a central understanding of what medical respite care is. It is also important to understand what medical respite care is not. And medical respite care is not the same as skilled nursing or skilled nursing facilities, assisted living, long-term care, supportive housing, or caregiver respite. Although these are all important services and resources, medical respite care does not provide the same level or duration of care as any of these particular services. So starting kind of top level, and we're going to work our way down through these framework and resources, we want to acknowledge and describe what the philosophy of medical respite care is. And part of our philosophy is grounded in the mission of the council and our work here, and really understanding that we know that housing is healthcare. Having a safe place to be is part of the healthcare process and critical for healthcare process. What we want to do within medical respite care is provide a space and provide dignity in the healing process. We want to make sure that people are able to meet their basic needs. We want to make sure that medical respite care provides an opportunity for rest and recovery. That as a program, it's filling the gap in the healthcare and housing continuums. And we want to make sure that we are connecting people to health and working towards the greater goal of housing. So these are our underlying philosophies that inform all of our foundational resources of the guiding principles, the standards, and the models of medical respite care. So when we get back to it, these are the things that we want to make sure that we are doing. So we're going to start with the guiding principles for medical respite care, because these are really grounded in that philosophy of medical respite. The guiding principles for medical respite care were established to describe approaches to care that create healing and safe environments for people experiencing homelessness. Our guiding principles are what help us enact those core philosophies that I just described there, and really helping enable us to meet that goal of housing and healthcare. The guiding principles for medical respite care were developed from the field of medical respite through focus groups and formal listening sessions with providers and consumers who helped determine what the common elements that make a medical respite program successful are. These results were then integrated with existing evidence and best practices for providing care to people experiencing homelessness. So combined together, we were able to establish 4 guiding principles for medical respite care, which are depicted here. And we're going to take a moment to walk through what each of these guiding principles are. So the first that we're going to start with is trauma-informed care. Trauma-informed care occurs when a program, organization, or system realizes the widespread impact of trauma and understands potential paths for recovery. It recognizes the signs and symptoms of trauma in clients, family, staff, and others involved in the system, and responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. So what does this look like in medical respite care? Trauma-informed care in medical respite recognizes the relationship of trauma and homelessness. It also prepares programs to address trauma related to recent medical events. So specific to medical respite care programs, we're working with folks who've had a recent medical event that required hospitalization or admission into that respite program. We need to recognize and be able to respond to the trauma affiliated with that very recent event. Trauma-informed care and medical respite also promotes safety, recovery, and ensures accessibility of programs to any client or person who might need that service. And really importantly, right, underlying all of this is trauma-informed care helps support the providers and staff within the programs as well. So trauma-informed care is really important and critical both for the clients and the staff of the programs. Our second guiding principle is client-centered practice. Client-centered practice accepts and addresses all components of the person, physical, mental, and psychosocial. A client-centered organization sees the individual client's specific health needs and desired health outcomes as the driving force behind all healthcare decisions and quality measurements. Within medical respite care, this means that the goals and priorities of the client remain central to decision-making, care planning, and discharge planning, understanding that each person provides their own unique experience and preferences. It means that programs are equipped to address all needs and priorities of the person through direct services, community partnerships, and engaging clients in quality improvement activities. Client-centered practice also recognizes intersectionality as it relates to homelessness and health and works to identify, address, and prevent bias and stigma related to that intersectionality. Our third guiding principle is collaborative care. Collaborative care, by definition, was initially developed for primary care as an evidence-based approach to integrate healthcare professionals and support systematic communication and shared treatment goals. People experiencing homelessness often present with multiple complex needs that require engagement with multiple systems and providers to address. Medical respite programs must be able to communicate across services and systems effectively, whether that be homelessness, housing, healthcare systems, and be able to collaborate at the micro and macro level to be a bridge between housing and healthcare continuums. We also want to allow and ensure collaboration with the client to be able to address their priorities and address their needs holistically. What this looks like pragmatically is that programs often must develop collaborative relationships with community entities that are not part of their typical operational structure, such as hospitals, continuums of care, housing programs, and community providers such as health centers or behavioral health programs. Our last guiding principle is disrupting the cycle of homelessness, and this is really critical. I think what gets complicated a lot of times for programs is that there's not always a direct pathway from medical respite care into housing because of barriers in our systems. However, it's the firm belief of the Council and of the National Institute for Medical Respite Care that housing is healthcare, right? Going back to that grounded philosophy, and therefore safe, accessible, and affordable housing is a basic human right for every individual. Even if we are not able to directly move someone from medical respite care into housing, we want to disrupt that process where the person is sort of cycling through programs and services and really move them further along towards a closer point of housing. What might that look like is recognizing the direct relationship between housing and healthcare, and really requires programs to be intentional in moving clients into housing or completing steps to move someone further in the continuum towards permanent housing while they're in medical respite care. A medical respite care admission is a point in which clients can rest and address acute and chronic health needs. This stability of having their basic needs met might allow them to be able to engage in services and take steps towards housing that have not otherwise been accessible to them. Linking back to the idea of having a trauma-informed environment, clients can build relationships with providers who are able to meet their needs and understand the complexities of homelessness. This trust supports engagement in an often long and frustrating process towards achieving housing stability that can be really unique to the medical respite care setting. So the next foundational resource that I'm going to talk about is our standards for medical respite care programs, or what we often refer to as the standards. The standards are the oldest and original foundational resource that have been a substantial tool for developing and operating programs to reference when putting together their medical respite program operations. The standards are a guiding framework to help medical respite care programs operate safely, effectively, and seamlessly with local healthcare systems and to promote program development and growth. Each of the standards includes descriptive criteria which guides programs in determining whether or not they have met each of those standards. These criteria are sort of the nuts and bolts of the standards and are used to inform and support development of program policies, procedures, and practices. Although programs, again, represent a lot of diversity in staffing, facility models, models of care, different partnerships, the standards help ensure that the care delivered within any model of care is high quality and person-centered. I'm going to do a little bit of a review of the history of the standards and how they were developed. So initially in 2011, the Steering Committee of the Respite Care Providers Network, or the RCPN, addressed the need to establish the standards for medical respite care and developed a task force that was charged with developing standards that aligned with healthcare industry standards related to patient care, reflected the needs of patients being served in the medical respite setting, promoted quality care and improved health, and were achievable for a range of medical respite programs with a varying level of resources. So there's always been acknowledgement that medical respite programs are going to look unique across communities, and the standards were intended to be a central resource regardless of how programs were structured. The work group that was established in 2011 developed the initial standards for medical respite care programs, which were published in 2016 and made available to the field. This process involved engagement with programs across the country and the dedicated work of the RCPN members. In 2021, a work group of the RCPM was formed again to build on the work of the initial task group and to update the standards and review them to make sure that they were based on and included new and evidence-based practices, that they were aligned with continued development of models of medical respite care programs, and were responsive to changes in policy and healthcare systems that had happened since the group initially formed in 2011. So as a result, if you have been around the medical respite community for a while, you know that the original standards for medical respite care included 7 standards. Due to the updates in 2021, there are now 8 standards for medical respite care. So standard 1 is that the medical respite program provides safe and quality accommodations. Standard 2 is that medical respite programs provide quality environmental services. Standard 3, medical respite programs manage safe and timely care transitions to medical respite from acute care, specialty care, or community settings. Standard 4, medical respite programs administer high quality and post-acute clinical care. Standard 5, medical respite programs assist in healthcare coordination, provide wraparound services, and facilitate access to comprehensive support services. Standard 6, medical respite programs facilitate safe and appropriate care transitions out of medical respite care. Standard 7, medical respite care personnel are equipped to address the needs of people experiencing homelessness. And Standard 8, which was the new standard, is that medical respite care is driven by quality improvement. As I noted, each of these standards includes specific defining criteria, which guides programs in meeting these standards. The criterion range in scope, such as having direct guidance that programs must have written policies and procedures for responding to life-threatening emergency, to more comprehensive criteria that each client in the program must have an individualized care plan. It is our ideal that newer programs aim to meet 70% of the standards. It's not expected that a new program would meet the standards 100%, but we want programs to have a goal to increase their alignment with their standards to be able to meet almost all standards as part of the program's operation. Evaluating your program and your alignment with the standards can be a really helpful activity to develop quality improvement or overarching goals for your program's growth and development. We have an additional webinar that talks about the development and more in depth about the standards for medical respite care programs. So if you want to learn more, I would encourage you to look at that webinar recording, and we can share that link in a little bit as well. Where we want to spend a good chunk of our time today is talking about the models of medical respite care, in part because we recently updated this resource. And again, I know Stephen put that link in the chat, but we have updated the models of medical respite care after some opportunity to apply the models of care in practice and be able to refine them so that they really truly reflect the work of medical respite care programs. The models of medical respite care help us establish clear guidance on what actually constitutes medical respite care. All models include the same key components and program services, which we'll talk about in a minute. All of the models are designed to allow programs to respond to community and client needs and helpfully integrate partnerships into service delivery. We know that programs really operate because of partnerships that happen within their community, and the models of care reflect programs' ability to do that and the way that they put that together. We have 4 models of care: the coordinated care model, the coordinated clinical care model, the integrated clinical care model, and the comprehensive clinical care model. So we'll dive into what those look like, but first we're going to talk about central aspects of all of these models. So first, within medical respite service delivery, the essential goal of medical respite care is to provide a safe place to heal and recover. Programs must also ensure that connecting clients to healthcare services is a top priority. All models at minimum should include the key components described here. These include 24-hour access to a bed, 3 meals a day, transportation to any and all medical appointments, access to a phone for telehealth and communication related to medical needs, safe space to store personal items, and a wellness check at least 1 time every 24 hours. Helpfully, these key components are all criterion of the standards for medical respite care programs. So even by meeting these essential services in these key components, programs are on their way to meeting the standards. In addition to offering the key components, programs should also facilitate access to the program services described here, which include care coordination, case management, medical clinical care, medication support or medication management, and behavioral health care. What changes across the models is the location, intensity, and delivery of the services, and which informs the acuity and types of conditions that a program can safely serve and support within their program. So within the program services, we have what we've identified as essential program services, and these are the case management and care coordination pieces. These are critical activities that address the program client's medical and social needs and are part of all models of medical respite care. So we want case management and care coordination services to address both the medical needs and social needs of the individual person. You can see how this links to our guiding principles around client-centered and collaborative care. Examples of case management and care coordination to meet medical needs might include, but are certainly not inclusive of all, different ways that this can look, but we might talk about identifying a care plan, connecting someone to a primary care home or home health care, accessing medication in pharmacies. These are all different case management and care coordination activities that help meet somebody's medical needs. Similarly, we want to make sure that case management and care coordination services are meeting individual social needs. Examples of this might be conducting a needs assessment, developing the person's discharge plan, or identifying their need for vital documents and starting the application process for those. So all models of care offer these essential programs and services of case management and care coordination. We have additional program services, as mentioned on the previous slide, of medical clinical care, medication management and support, and behavioral health services. These program services is where we start to see variability and what changes each program's model of care, what they identify. So I'm going to share how we've defined these program services before we dive into what that looks like into each model. When we're talking about medical and clinical care, this includes assessment of baseline patient health, ongoing reassessment to determine if interventions are effective, what the needs are, and the person's readiness for program discharge. Medical and clinical care should be delivered by qualified healthcare personnel, and high quality clinical care, again, is client-centered and responds to the patient's needs and goals and often requires interdisciplinary teamwork. Also important to note is the definition of medication management and support. So medication support is the support that enables a person to manage their medications, for the person to be able to self-manage their medications. And that includes any activity related to individual medication management. Conversely, medication management by healthcare providers is defined as the practice of prescribing, administering, or dispensing medication by qualified personnel and monitoring for efficacy and toxicity. So you can see where a really big difference is here in what medication management by healthcare provider looks like versus somebody else managing their own medications there. And that's going to change by the model of care. And then we've defined behavioral health using the definition put forward by the Substance Abuse and Mental Health Services Administration, known as SAMHSA, which is the promotion of mental health, resilience, and well-being, the treatment of mental health and substance use disorders, and the support of those who experience and/or are in recovery from these experiences or conditions. So when we use the term behavioral health, we're talking about both mental health and substance use. Before we look at what each of the models are, we want to acknowledge what the role of partnerships are. There are very few programs that provide all of these services under one primary operational organization. We've talked about collaboration being a guiding principle for care, which means that oftentimes we need to engage with other community entities and partners. So we've defined two different levels of partnerships that might happen within the medical respite program to provide services. The first is the collaborative relationship. This is where a medical respite program uses a community organization through its typical structures or pathways for accessing services. Contrasting with that, formal partnerships is when a medical respite program has a formalized relationship with the community organization or service, and these services are meaningfully integrated within the medical respite program to provide more direct access to services. So to compare the two, a collaborative relationship might be using its traditional pathways. So a case manager might call a community primary care clinic to help a person set up an appointment through their traditional appointment line. A formal partnership might look like if there's a medical respite program based in a shelter and the Healthcare for the Homeless program has a clinic on the first floor, that clinic then has open spots for medical respite care clients to be able to access those healthcare services when they're needed. This type of relationship often then requires some sort of contract or MOU about how those services will be operated. And the staff can communicate with each other and support the client directly accessing those services. So partnerships may result in the services being provided on site or as through direct access, which means the person does not have barriers to getting to that and can access those services as needed. Collaboration, there might be wait times or there might be different referral pathways that the person needs to take, but the staff of the medical respite program can help facilitate those connections, supporting the person to accessing those resources and scheduling around that. So there's sort of these two different intensities. The role of the partnership will help inform what the program's model of care is because it changes what direct access the client has. So the important question that programs might be considering, right, is how do I know or how do I determine what my program's model of care is? So all models of care encompass care coordination and clinical services, and each model is really differentiated by the way clients of a program access the medical, clinical, and behavioral health services. So again, when we're talking about direct access, we're meaning the services that clients can receive without either having to leave the program or is completely facilitated by staff of the program. So every program, as we noted, should include the key components and the essential program services of case management and care coordination for medical and social needs. From there, how the client accesses the remaining services, medical, clinical care, medication support or management, and behavioral health is what determines what the model of care is and is going to change depending on the model of care. So when you're determining the best fit or the model that most fits the program services, you should consider what the clinical services the client of the program have direct access to, the intensity of those services providers through that on-site or direct access, and what formal partnerships the program has to be able to provide those services and or are provided by the staff of the operating organization. So now we're going to walk through each of the models of care, which will hopefully kind of clarify any additional questions as a result of that. So first we have the coordinated care model. So the coordinated care model includes those essential services of case management and care coordination for medical and social needs. Medical needs in this model are addressed through community-based or externally located medical services. There's not medical staffing on site or as part of the operating medical respite care program. In this model, it is only medication support so that clients are responsible for self-managing their medication. Case management and care coordination will support the clients in being able to do that. And then also identifying the need for behavioral health services and helping facilitate that connection to existing community behavioral health services. In the coordinated clinical care model, just like all models, we're going to have the case management and care coordination to meet medical and social needs. What differentiates this model then is that there can be some provision of basic on-site medical and clinical services and along with coordination with community-based providers. So provision of basic on-site medical services may be something like medication reconciliation, basic vital signs by a licensed medical provider who's able to provide those services. Medication management. So instead of only offering medication support to the person through case management and care coordination, there may be additional medication education or review reconciliation that happens because of the licensed medical staff that are part of this program model. Similarly, there will be identification for and connection to community behavioral health services. In the integrated clinical care model, as you'll know, there's some similarities across all these models. Again, there's going to be case management and care coordination services for medical and social needs. What changes here then is the intensity of the clinical services. In the integrated clinical care model, as the name suggests, clinical services are integrated on site and allow for condition monitoring as well as coordination with community-based providers. In this model then too, the program can offer medication management, which supports client self-management, but also has licensed clinical staff to provide medication education, reconciliation, and prescribing as needed. Because there might be more medical monitoring in this model through prescribing and management of conditions, it's important then that this model also includes connection and transition to community-based primary care or a health home before the person discharges from the program, if that is going to change from discharge or not. So if the person is accessing medical care through the medical respite program, say from the health center that is operating that program, the transition needs to happen so that the person knows who their provider is at the health center post-discharge and where to go to receive those services. Behavioral health services also change a little bit in this model. In addition to screening and identifying a need for services, there may also be on-site behavioral health services offered, such as counseling, group therapy services, or other activities, in addition to referrals to community partners as needed for additional supports and services. This model also has 24-hour program staffing and on-call medical support to support that higher intensity of conditions. And then finally, we have the comprehensive clinical care model, which, as the name suggests, increases the intensity and comprehensiveness of the clinical care provided. Just like the other models, case management and care coordination for medical and social needs is an essential part of this model. What changes then again is the on-site clinical services, which become more comprehensive and may include things like daily condition monitoring, in addition to coordination with any community-based providers. Medication management by the licensed clinical staff might include education, reconciliation, prescribing, and administration, in addition to supporting medication self-management for the person. This also includes connection and transition to primary care or health homes before discharge. Again, if the majority of medical needs have been managed by the on-site clinical staff of the program, there needs to be a plan for transition for that person of where those services will continue after discharge. Behavioral health services are offered through screening, on-site care, medication prescribing, and referrals to community partners. So again, the intensity increases in that this model has staff that are able to prescribe medication to address behavioral health needs. This program also has 24-hour program staffing, but needs to have staff who are trained or have the ability to monitor higher level acuity medical needs, in addition to providing on-call medical support. So often an associated question with that is, what does staffing or what are staffing requirements for each of the models of care? So we want programs to consider what their local and state licensing laws are for structure, supervision, and credentials of program staff to be able to provide the services described. So we don't have a prescription for what staff you need to be able to implement the model, but you need to look at what the roles and skills are and what is your state licensing indicate to be able to do that. So in some cases, an RN or an LPN might have different supervision requirements for them to be able to do activities such as medication reconciliation. So you need to meet all of those licensing guidelines for those roles and staff to be able to meet those roles within the model of care. So really appropriate staffing for each model is indicated by the skills needed to provide those key components and essential services that are described in each model. So we certainly have some resources that describe what that can look like, but you will need to figure that out, what that looks like specific to your state and the roles of those different staff. I also want to acknowledge that the models of care provide a central definition of how services are offered in programs, but they don't reflect all of the services and offerings that happen within medical respite care programs. I know that you all are doing and providing really incredible services on the ground, like acupuncture and yoga and pet therapy and recreation therapy. We know that those are not reflected in the model. So as you're talking about your programs to partners and funders and people you need on board for your program, please highlight those services beyond your beyond your model of care. We know that additional programming and services enhance wellness of clients and the recovery process, and we recommend you implementing those services in the way that you have capacity to do so. But we note that that is beyond what we are showing here in the models of care. So with that, I'm going to turn it over to Julia, who's going to talk with us about how this framework really relates to certification, which we'll be rolling out very soon. So I'll turn it over to you, Julia.
Thank you, Caitlin. Thanks so much. Hi, everyone. It's so nice to be with you this afternoon. Thank you for joining us. My name is Julia Dobbins. I am the Director of Medical Respite here at the National Healthcare for the Homeless Council and with the National Institute for Medical Respite Care. And Caitlin has just gone over the framework of medical respite care, what we really see as the backbone of this practice. And I am not going to miss an opportunity to elevate how this relates to our new medical respite certification process, which we are rolling out next week, less than a week from today, on April 1st. So as Caitlin shared, we're really seeing the framework of medical respite being these guiding principles, the standards of care, and then also models for medical respite care. And we are using these tools and these frameworks as the scaffolding for our medical respite certification. So as your community is thinking about pursuing certification for your medical respite program, we want this to be an open book test. I say that all the time so that you understand that these are the components that we're going to be looking at with your program. So we're going to be looking at your fidelity to the guiding principles of medical respite care, your fidelity to the standards for medical respite. We want to see evidence of how you are meaningfully engaging with clients and incorporating their feedback into your programming. And we want to understand better what your model of care is. Next slide, please. So we really see this certification process as an opportunity for you to demonstrate your organization's commitment to this framework for medical respite care. Our vision and hope for what certification will do for our collective field of medical respite is be able to demonstrate quality to your clients, to your funders, to your partners. Hopefully that will help streamline some negotiations with funders. We really want to enhance our internal quality improvement initiatives, maximize your impact, and also we're wanting to elevate the field of medical respite care nationally. So when we say this is what medical respite care is, we can understand that this is what it looks like across every community, even with a lot of diversity and creativity and ingenuity and scrappiness for each program. There is this level of quality that is expected of all programs. Next slide, please. So we've been working on certification for literal years now. So this is a big deal for us to be where we are. And as part of the development of this certification process, we did do some field testing. We did a field test and a pilot test of the structure of our certification and worked with over 15 programs. Who all 15 programs have achieved certification. And if you were able to attend our February RCPN all-member meeting, this might be familiar information to you because Stephen did a very comprehensive overview of our testing phases. But I just want to highlight some of our findings from those testing phases. First, folks shared that in their opinion, what would be most valuable about becoming certified is that they are now able to demonstrate quality to their contracted partners and funders. So again, that's something that's part of our vision for certification. I'm also really pleased to share that when asking all 15 programs, giving them the scenario, imagine the only thing you know about another medical respite program is that they have been certified by NIMARC. How confident would you be in referring someone else to that program? 100% of those participants said that they would feel confident referring another client to a program that was certified by NIMARC. A couple of the challenges that came up from the testing phase that we just want to note really is we understand that medical respite programs are working really hard these days, and most programs have more clients than they have staff available to provide care for clients. So there can be competing priorities when you are trying to just operate your program, sustain your funding for your program, maintain your partnerships, and then also take on the responsibility of going through a certification process. We're aware of that. We also learned that certification is a time commitment for programs, and we want to make sure folks are aware of that. So on average, we saw that programs were spending between 40 to 60 hours working to complete their certification. Next slide, please. Also want to highlight a couple of quotes from participants in the testing phase that I think are very powerful. So programs said that going through certification gave them a sense of legitimacy and confidence that felt really good. It was time spent investing in their team and in their program. It gave them the opportunity to take those unwritten procedures and make them more official. And then we didn't say that one of the guiding principles was humility. So I'm going to highlight one that talks about how great our team is, but said that they can't speak highly enough of the assistance they received. And that's really what we are seeing this certification process as, is a technical assistance process where we can work with your program to help you come up to certification and get your policies and procedures and partnerships in place so that you can feel really confident in how you are operating and in the decision making of your services. Next slide, please. So where do we go from here as it relates to certification? Just want to share that we have some really great web resources on our website. I think Stephen has put them in the chat, but that's a great place to read more. There's an FAQ about certification, the guidebook for certification that really will just walk you through beginning to end what the certification process will look like. Also on the website is our testing phase report, so you can get more understanding of the due diligence of this process, what it has looked like developing certification over the last almost 3 years. Next, it's time for you to think about, is your community and your program ready to seek certification? So some of the things to keep in mind is that your program has to have been open, operating, and serving clients for over a year to seek certification. You do have to have an up-to-date profile in our directory. We're requiring that of all programs. You also need to have a plan and prepare for how are we going to dedicate the staff time to this process. It's really important to us that you are able to be successful in this process. We will do our part to help you be successful, but we need to make sure that you have the staff time carved out so that your program can be successful. And then I think it would also be helpful to spend some time going through the standards and the guiding principles and really thinking through, where are we in this process? Are we ready to do some work here? We do not require you to be at 100% for the standards in order to seek certification. Like I said, this is a technical assistance process, so it's okay for your program to be where you are. You don't have to be perfect or doing everything exactly the way that everything is written in our resources. We are there to support you and walk you through it. And then the next piece is applications open on April 1st. So put a reminder in your calendar on your phone to submit an application starting next Tuesday. And applications will be open until the 15th. This is the first application round. We will be opening multiple rounds of applications. We are anticipating a good amount of interest and excitement about certification. So we have a plan for that, but we won't know until next week how many applications we'll get. So we're asking for your grace as we figure this out for the first time. And we're really, really excited to be working with you in this process. So I know there are going to be some questions about this. One that I maybe can get in front of: certification is being offered right now at no cost to programs. We are able, through support from some of our partners, to do that. Our hope is to continue to do that, but we're looking for additional partners to support certification. So for now, there is no cost associated with the certification process. Okay, I think that's my piece on certification. I'm going to pass it back to Caitlin and we'll jump into some questions.
Perfect. Yeah, I'm going to stop sharing and I'll invite Stephen to come off as well. And if you have not met Stephen yet, he is the brain behind certification. So Stephen, if you want to introduce yourself real quick, and then I'll figure out which questions we want to start with.
Sure. Really happy to be here with you all, and wonderful presentation, Caitlin. Thanks for that. And Julia. My name's Stephen Wilder. I'm a senior medical respite manager with the National Healthcare for the Homeless Council. I've been with the organization for 4 years, and I live in Nashville, Tennessee. And yeah, it's been a challenge and a pleasure to, over the last few years, really thoroughly research and test and refine through multiple iterations this certification process. But we're just absolutely thrilled about the potential and the feedback that we've gotten from folks who have walked through that process. And we really think it's going to be a tool for you all to utilize and hopefully to elevate just our field broadly, nationally, and elevate the incredible work that each of you is doing in your specific communities. So we hope it's really useful. That is our intention.
Great. And we do have one specific certification related question we'll start off with before diving into others. Is there an estimate of when additional rounds will be open for applications?
There is an estimate, but as Julia mentioned, we don't exactly know what the initial influx of demand will be and what that will look like, and that'll kind of define how quickly we can work through that initial group of applications that we receive. So we expect it to be there to, no matter what, be another application window that opens during this calendar year. So hopefully later in the year at the latest, maybe October or November kind of time. And it's possible that there could be one before that if it's more of a slow fizzle as people get used to the fact that this is a service that's available to them. So I hope that's helpful.
Great.
Caitlin, before moving on, there was a question that went to the answered column, but I thought was really great, and I'd love for either you or Julia to try to answer this not so simple question. But are medical respite programs considered homeless services programs or a medical program? I asked because in my city, where shelter programs can be housed per zoning is different than where medical rehab programs can be housed. And that question was from Teresa. I thought it was really good.
Yeah, one of our favorites, because we like to answer all of our TA responses in medical respite with, well, it depends. And this is no unique question related to that. So I think, Teresa, you've highlighted a little bit around the it depends piece of it, because local ordinances and zoning laws are going to be variable. There's not one specific, there's not an existing designation of medical respite care program for licensing or zoning purposes, is the very short answer. The lengthier answer, which Julia can certainly add on to, is that determining what fits best for your program is going to depend on a couple of different things. Sometimes it's related to your funding source in terms of accessing HUD dollars or continuum of care dollars. You may need to designate yourself as a shelter, emergency shelter, transitional shelter. Different programs do different things based on what those community and funding requirements are, versus identifying themselves as a medical facility. However, in the state of Ohio has said medical respite programs must be licensed as assisted living facilities. Although those programs don't provide assisted living services, they provide medical respite services. That is their designation to be able to operate within that state. So there's some variability across communities of what that looks like, which then indicates what type of zoning you're able to do. And different entities have different rules about, can the clinic be in the shelter, or does it need to be next door to the shelter with two different entry points? Again, communities navigate that. So learning what those local zoning laws are is really the best guidance for you and what that looks like. But Julia or Stephen, do you have anything to add?
I was just going to add, I think one thing to it's a frustrating reality of medical respite that it's very infrequently, this is the correct way to do it. It is often, well, it depends on your community, and this is how every community has done it differently. But I think one important exercise is to think about what would the potential consequences be of this decision. So where we have seen some concerns come up is how medical respite programs are designated by their local COC. What does that relationship look like with the local COC? And you want to make sure that while somebody is in your medical respite program, that is not disrupting their homelessness status. And so I think that's an important thing, an important issue to just be aware of that could potentially be a consequence, an unintended consequence of what your zoning is. So I think that's a conversation to have with your COC. I think programs really are across the board on this. So it's going to take a little bit of negotiation with some of your partners on what makes most sense for where we are and how this community operates.
Great. We have some additional really good questions in the Q&A. So is there help available with developing and writing out policies and procedures? And I think this is a two-tiered question. I'm going to say, as part of regular technical assistance with the National Healthcare for the Homeless Council, we have a few resources that we can support programs. Technical assistance can be kind of a one-time conversation, connection to resources. We have examples of policies and procedures on the website. If a program wants more intensive consultation, which is paid consultation, to be able to review policies and procedures, that's available as well. But we do have some initial resources via our technical assistance pathways to help guide programs. That is available to all programs at any point in time. But I'll defer to Stephen on what that might look like within the certification process.
Yeah, thanks for that description, Caitlin. And it looks really similar. As Caitlin said, we have, I think, the most valuable thing we have to offer in terms of this conversation is sample policies and procedures from other programs, real world, tangible examples that folks can take and adapt and replicate to their unique context, because we know no program is operating in exactly the same kind of space and context. So that can be really helpful. Yeah, in the certification process, we do not write or create things for programs. That's a little beyond the assistance that we can provide, but we can really robustly provide those examples. And also, something that's unique about the certification process, I think, is just the consistency of the meetings. So we have like this regular cadence that folks found very helpful of checking in monthly. There's usually like a bite-sized piece of homework between each of those monthly check-in calls. And so being able to talk about it once, give you all some sample resources, and then a program being able to come back the next month and say, can you look over what we've drafted, provide feedback on that? We can provide kind of iterative support over the course of that process. Great question.
And there's another clarifying question. If a program applies by April 15th, will they then be working on the certification process over the next 6 months? Or is the expectation that we would already have put in the 60 hours when we apply?
Great question. Yes. The process would begin when a program is invited to begin the certification process. So it is not an expectation that you've already put in that 40 to 60 hours before applying. So when folks apply, our team will have the responsibility of sorting through the applications and managing our own capacity for this initial round, and then inviting folks to formally choose to begin the certification process. So what that'll probably look like is inviting folks to have consultation meetings, where we can really dive more in depth and talk through individual, like specific, unique elements of your program and what you're trying to accomplish by participating in the certification process, so that folks can make a really informed decision before officially signing a participation agreement and initiating the process. So yeah, it would be 6 months probably by the time we really get everything rolling. Sometime in May is when the participation agreement would be signed and the process would begin.
Great. And then another related and important question is, when a program applies for certification, do they need to pick between a specific model already, as I feel ours is between 2 of the models, or does that help get identified in the process?
that is part of the process, and we will absolutely help folks identify the model of medical respite care. And it's not at all uncommon to look through those models and be like, I see sprinklings of this model, and I feel like we fall in between. That's something that we can help folks navigate. And we've created a mechanism that we feel is really helpful, an inventory tool that folks can make an itemized inventory of the services that they offer in a really structured way. So I'm hoping most folks were able to find a model that they felt really comfortable with, that they fit into.
Yeah, and it was that certification testing process that really helped us refine these models to, actually applying them to programs is what helped us refine them in a way that we think really can capture and encompass all programs. Noting again that you all are doing really amazing things above and beyond what these models include, and we want to highlight that as well. So we don't have any other questions in the Q&A, so I'm going to make a last call to submit any questions into the Q&A if you have them. If not, I'm going to attempt to launch a poll about today's webinar. So we can take that. And we do have one question. Excellent. Can the 24-hour program staffing requirement be a staff member available by phone on the weekends? Shelter staff is available on site 24 hours, but medical program staff is Monday through Friday. So yes, based on the models of care, it is not 24-hour clinical staffing, it is 24-hour staffing, and that definitely looks differently. I think it would be incredible if a program could offer 24-hour medical staffing, but that's just not the reality. So 24-hour staffing, so that there's somebody on site and present 24 hours a day. So that might be shelter staff or milieu staff, whatever that might look like. What goes in addition to that is having a mechanism to access medical staff, which is sometimes through an urgent care or on-call line, medical on-call line, whatever it might look, to kind of adjunct when those medical staff are not on site. And then another question is, are we expecting certification applications to be competitive? What would keep someone from being accepted?
Yeah, that's an astute question, and transparently, the one that's toughest for us to navigate. And that's just because at the beginning of this process, as we launch this brand new program, there's a limited capacity of programs that we can walk through the certification process with at a single time in order to kind of maintain the integrity of that process, which is really time intensive on our end at the council as well. So it's not competitive in terms of like folks not being permitted to, as long as they meet those minimum eligibility criteria that Julia outlined in her presentation. It's not competitive in terms of like folks being not having the opportunity to participate, period, in the certification process. However, in terms of we may, if there is a large amount of demand right at the beginning, have to be selective about the order in which we can certify folks and walk through that certification process. So we're making those decisions based on wanting to have a representative sample of the field participate in that first process in the first 6 months, as well as some other considerations around like are folks for sure prepared to invest the time and resources to go through and finish the entire process. There are some funder considerations that we have to keep in mind, since we have a few generous funding entities who have made it possible to do this without charging a fee to programs. So those are kind of the factors that are going to guide our determinations if we have to be selective for this first class of programs that apply in April. But folks will have multiple opportunities on an ongoing basis to apply for this.
Great. We still have questions pouring in. I do want to note, because we have asked programs to submit an updated program profile, our updated medical respite directory is in progress. If we could put up a construction sign, we would. So the new medical respite directory will be launching soon, and that will reflect the new program profiles that you've submitted. So if you have done it and you feel like it's not updated on the website yet, you are correct. It is coming, so stay tuned. We're excited about the new directory that is coming up. So if you have any questions about, if you can't remember, did I do this form or not, you can certainly reach out to us and we can double check that you have submitted a new profile. And then we have, I'm going to do maybe one more question. If you have it figured out, Stephen, if folks are not selected for the April cohort, will they need to reapply, or does the application roll over into the next period?
Yeah, that's a great question as well. I believe we are going to ask folks to reapply. However, the application process for this, because this is a technical assistance process and folks are welcome, we want people to participate. It is not a lengthy or arduous application process to fill out, but we will ask folks to complete a new interest form the next time there's an application window.
Great, thank you, Stephen. So we are at our time. So I just want to thank both Julia and Stephen for joining today and offering this additional insight into the certification process. Thank you all for joining. I think our foundational documents are a really critical part of the services that we do. And even if you've been doing this a long time, it's nice to have a refresher around the why and the philosophy around what we're doing. So thank you for joining us today. Please don't hesitate to reach out with your questions around certification, technical assistance, the how do I figure this out? We are here for you and for that. So we hope to see you all at our upcoming activities and hopefully at conference in Baltimore. I'd be remiss not to share that. Hopefully we'll see you all in person in May, and we will all talk again soon. Thanks so much, everybody.
Thank you all.